So first, we'll start with introductions. Thank you to everyone here today who's joining us. We are really excited to have you hear from one of the preeminent researchers and clinicians in myositis joining us from Johns Hopkins today. I'm Shannon Malloy, Cure JM's Director of Development and Community Engagement. And what I do is try to help all of the families learn all of the latest information in how to care for themselves or for their child and grandchild. We're very glad to have some of our grandparents on here as well today. So we are extremely pleased to have a presentation for you today about something that I think some of us might have heard a little bit about before, which is a treatment called JAK inhibitors. So this is something new. So it's kind of confusing to all of us who are learning about it for the first time. So Dr. Julie Paik is going to walk us through some information about how JAKs came to be, about how they're used in myositis, and about any questions that we might have about side effects and where they may be in the future of JDM care for our kids. So with that, I'd like to introduce Dr. Julie Paik. Dr. Paik completed her medical school training at the George Washington University School of Medicine in Washington, D.C. She then completed her residency and chief residency at UCLA Cedars-Sinai's VA Medical Center in Los Angeles. She completed her fellowship at Johns Hopkins and joined the faculty in 2013. We are so grateful to have her with us today. She currently treats patients at the Johns Hopkins Myositis Center and Scleroderma Center. So her research interests are in both myositis and scleroderma and overlap myositis. She also has a special interest, which I think all of us here do as well, in new treatments for hard to treat dermatomyositis. So new treatments are something that every parent on this call is interested in. I think I'll speak for almost all of us when I say, steroids and methotrexate, although wonderful, are not something that many families are eager to stay on for the long term. So we're all here today to learn about what our different options might be. So with that, Julie, I think we had quite a few families that weren't able to join that sent in their questions. And they kind of targeted around a couple of different themes. So we might ask you if you might be willing to answer a few of those questions for our families here today. So the first question is, when we may have to stop sharing so we can see your
sure.
face, I think. Let me see if.
Okay.
Wonderful. I can spotlight you. Okay. Great. So one first question that our families had is, when we talk about a JAK, could you tell us a little bit about the history of JAKs and what they are and what they do?
Yes. So the JAK inhibitors have been around about 15 years, and they've been using it on the oncology space for a long time to treat some blood cancers and things like this. And then it gradually moved into the rheumatology space about probably, like I said, I think 15 years ago. Where it was largely first FDA approved in the United States. The first drug was tofacitinib, which is a pan-JAK inhibitor for rheumatoid arthritis. And then it started to kind of like expand into different, autoimmune diseases. And since then, it's been FDA approved to treat, you guys probably all know, like juvenile arthritis, psoriatic arthritis. They've looked at it in alopecia areata, where all the, suddenly some patient's hair all falls out, unfortunately, makes the hair grow back. And vitiligo, where, you can get like white patches in the skin. And so I think when it first came out, and it was approved in RA, I remember everyone was like, this is going to change the face of rheumatology. And I remember thinking, like, will it really do that? And I think one of the key kind of important persons who contributed to discovery is John O'Shea at the NIH. And he had worked with Pfizer to, build this, the tofacitinib. And so in myositis, how I got involved and how I believed and truly believed that it can really change the landscape of autoimmune diseases is actually I credit my patients
Mm.
because I think it's just so important to listen to our patients, and I'm sure it's even more so. I have two young boys, and it's very important to listen to your patients and how they're feeling and how they're doing. And I remember distinctly one of my patients, we had tried every single medication under the roof, IVIG, rituximab, high dose steroids, for her dermatomyositis, and nothing had worked. But she had a little bit of, joint inflammation, which is not uncommon for our adult patients to get, multiple organs get involved beyond the skin or the muscle. And so I said, let's try this, new JAK inhibitor that just came and, on the market. And so when we tried that, it was astonishing to me, just so striking that all her skin, rash just melted away. And I always share this story, so I
Wow.
probably recorded this, but I have to share it because she's still my longstanding patient. I haven't seen her in a while, so maybe she's doing well. But she called crying, and I finally went to the beach and I could wear my swimsuit because the rash was like gone. And so I think I was just dumbfounded how fast the medication worked, especially compared to some of the other medications. And this is, of course, an adult dermatomyositis. And she also had some improvement in muscle strength. And that was the impetus, right? Like when you hear that kind of story, I was just so affected by it. And then realizing how many other patients could potentially benefit from it.
So
And so, yeah.
So what I think I hear you saying is this was used in other autoimmune conditions. You and some other researchers and clinicians and doctors saw that this might have potential in
Yes.
myositis.
Yes.
And so then could you tell us a little bit about how the research in myositis has, so you mentioned they've been around 15 years. How long have we been researching in myositis, and have we learned anything about the safety
Yes.
or
Yes.
how effective it might be?
Yes, yes. Yeah, so going back to that patient, so that was probably I still remember December, the fall of 2014. And so as I was saying, so whenever something like this happens, as a researcher, we're compelled to really share that data. And so we wrote this case report up. And then we met with Pfizer, who was the only company making this drug um, at the time. Now there's so many other companies making it, right? These JAK inhibitors. And led to the first proof of concept clinical trial. And I still remember though, in addition to our case report on December of 2014, it was December 24th, 2014, that in the New England Journal of Medicine, it came out on my feed that there was another case report in Germany of an adult patient with dermatomyositis who had failed everything else and used this medication, and she improved. So whenever something like this astonishing and striking comes out, then us researchers are excited to share that knowledge, and it should go in the literature to help other people.
Mhm.
So that was kind of the very initial phases. So I would say 2014.
And since then, we've learned that this is safe or effective, or what do you feel like we've learned from the research that's happened?
Yes. So after those case, reports that, we put out in the literature, it led to our at Hopkins Myositis Center, the first proof of concept trial where we looked at this medication in 10 patients with very resistant dermatomyositis. And these patients all took the medication for close to 2 years. And it was very safe. We didn't have anybody stop the medication because they had any major side effects. Um, and the beauty, I think, of the trial that we conducted was that it was required that they stop everything else because I really wanted to assess the pure efficacy of this type of medication, this class of medications. So again, highlighting, it was another just repetition. The patients within 4 weeks, I can see that their skin improved. It says something about my speaking language or something. I don't know what
Oh,
this.
it's not too complicated for us. We
Oh,
understand you
oh,
totally.
okay. Yeah, okay. No, something, it was wanted to share my language or something. Anyways, I just took it off. And so, yeah, so people tolerated it very well. Um, I think we had one patient who was, in her 80s. I think it was like late mid 80s, and she developed recurrent urinary tract infections, but still continued the medication. So I think the key class effect in terms of risks, side effects with this medication that has come out over the years is that there's an infection risk, right? And any of our immunosuppressants have an infection risk. And zoster is one of them, especially with this class of medications. And then there's also a kind of a black box warning by the FDA that there may be a risk of, cardiac events. So if you and cancer. So we have, but that's really specific to the RA literature. And when we looked at our cohort a couple years ago, I had a very phenomenal medical student. We had about 50 patients at that time who were on, tofacitinib, which is the first JAK in the US that was approved. Now there's many more. And no one developed cancer or anything like this. So I think it's TBD in terms of specifically in dermatomyositis, if that cancer risk is there. Yeah.
Okay, great. So I think you've mentioned quite a few JAKs are now available.
Yeah.
So it sounds like tofacitinib or Xeljanz, as we talk about it as parents, is the first JAK. But you've also mentioned a couple of others. Could you tell us a little bit about what JAKs either you guys are using at Johns Hopkins or that
Yeah.
you're aware of that are being used in myositis?
Yes. Yes. So the other one that came out pretty close in time to Xeljanz or tofacitinib was baricitinib. And so I feel like that medication has been actually used more frequently in a JDM that, speaking to my colleagues and things like this who are pediatric rheumatologists. And then I think it was AbbVie, I can't remember the company, but they came out with upadacitinib, which is another JAK inhibitor. And then there's also, JAK-TYK inhibitor, which is all in the same pathway, but a little bit more refined in dampening the inflammation more and potentially less side effects. So brepocitinib is also another one. Um, and then ruxolitinib has always been around for a long time, and that's the one that's in a cream form now. That's, you can use, and that's been published to put on the like rash on the skin for like vitiligo, and reports even in just skin predominant dermatomyositis that they put it on, kind of like if you have eczema and you put a steroid cream on, you can just get it and put it on. It's kind of expensive, but anyways.
Okay. So, just so for our parents that are following along at home, so we've talked a little bit about tofacitinib, which we might call Xeljanz, in some cases, baricitinib, which parents might call Olumiant, ruxolitinib, Jakafi, or the cream, which is a different name, Ozapella, and we can send you the spellings, and upadacitinib, which is Rinvoq.
Mm-hmm.
So could you tell us a little bit, because it sounds like you've also dealt with some toddlers. So for some of us, giving shots to toddlers or toddlers on prednisone or toddlers hooked up to an IVIG is really difficult.
Mm-hmm.
So when would a family, these are all pills, correct? That
Yes,
except for the
that's correct.
cream. So
Yeah.
when would a family want to discuss all the different options with their clinicians, and what questions might you as a doctor want to hear from a family who wants to understand their options?
Yes. So in the adult literature thus far, I think JAK inhibitors, it works in the muscle, but if someone has like severe muscle inflammation and they're very weak, I I still think that, IVIG is something that you would probably reach to. And if it was my own child, like I would rather have more data in the literature that supports that the muscle inflammation will be completely gone so my kid can play and, things like this. So I think, and the reason is that the JAK inhibitor story, it's very, very clear that it works beautifully in the skin, but it's still not 100% clear that it works beautifully in the muscle to dampen all that inflammation and make it completely go away. But IVIG, on the other hand, we know 100%, well, not 100%, because not everybody responds, but in patients who have severe weakness, they respond beautifully. So I think that's the key, like distinguishing like how much muscle involvement my child may have,
Mhm.
and then have that discussion. Um, but it's so common, like you said, my patients, I was just talking to her yesterday. She's just like so fed up with being on IVIG for years. And I just want to get off. And so
Yeah.
I think if someone has long-standing disease and has been on IVIG for years and wants to get off, I think that would be definitely, a consideration. Yeah.
Okay, so what I think I hear you saying is have a discussion with your doctor and say, here's the treatments I'm currently on and how they're impacting my life or my job or my ability to go to school. Might there be any other options? And that's a discussion that each parent and each patient should have with their doctor.
Yes.
What's so hard for us as parents is that so many of the cases respond so differently. So what works for one patient won't work for another. And so
Yeah.
that's why we all have to discuss all these options. But I find that this is really helpful to know options that might be out there
Hmm.
just to go and have those conversations. For example, are there any treatments, besides a shot or an infusion or a steroid that my particular situation could consider?
Yes.
Because
Yes.
there's no one size fits all, is there, for JDM?
Yes. Yes, that's right. That's right.
Okay, great. So another question we get a lot from our families, and I think you kind of talked about this a little bit, but how would the side effects of a JAK, so compared to the current treatments that we're on? And the majority of our families are on what we call the juvenile first line treatments, which is steroids, methotrexate, and IVIG in many cases. So would we know how the side effects compare to those, or would we want to take those on a case by case basis?
So I think in terms of methotrexate, so methotrexate and JAK inhibitors in the adult world, we use that a lot in combination together. And while I did tell you that we just don't know as well about how these JAK inhibitors work in the muscle, I think that interpretation and that kind of conclusion I came to is largely because the trials thus far have looked at only patients who have resistant
Mhm.
dermatomyositis, who have failed, these other agents. And so there's been a huge impetus with multiple trials now in the adult and juvenile populations, like I told you about in Paris right now with baricitinib for JDM, where they're using it in naive, like early onset, not resistant dermatomyositis to really get a sense. So I think going back to that first question, I think we'll learn more if you can use it up front and not just use it at the end. But going back to the question you just asked, I think it really depends in terms of side effects. Methotrexate is probably a little bit milder in terms of causing immunosuppression than causing a higher risk of infections than the JAK inhibitors. Um, but I think most people tolerate it pretty well. Like I haven't seen any major side effects. Um,
Great.
yeah. And then the IVIG, so both IVIG has this kind of risk on the black on the medication that there's a risk of clotting. So I think that would be, a little bit of a concern, if someone has a history of clotting in the family or something like that, especially to use both of them at the same time, like IVIG and a JAK might be a little bit concerning. Yeah.
Okay. So what I think I hear you saying is there's obviously side effects to every treatment. The
Hmm.
doctors consider these side effects very carefully
Yeah.
when considering what to prescribe. And so just having that conversation is really good. And then I think you said something at the very beginning, which I actually wrote down, which is that you listen to your patients, right?
Mhm.
So what that made me think of as a parent, remembering how hard it is to give shots to toddlers who also aren't sleeping because of the prednisone,
Yeah.
is that maybe the doctors might not be fully aware of how different medications and side effects are affecting your family. And so just bringing those concerns forward is something that you would want to hear as the doctor.
Yes, Absolutely. We want to know
Yeah.
everything. Well, at least I feel like we at our center we really do because it's so important to yes, the efficacy is important, but it's also the quality of life, you know. I
Yeah,
don't
we
want my
hear
patients, yeah, have headaches and be stuck to the pole, for how many days and just it's
we hear a lot from our parents that with methotrexate things may get worse over time. So either
Mm.
it's emotional or maybe it's physical. So for example, we were able to do that for 2 or 3 years, but now the child is throwing up in the morning just anticipating the shot. Or and so those are the kinds
Um,
of things that now it might be, to your point, it might be worth bringing up. Just, here's our experience at home, and this is sort of how these treatments
yes.
are affecting the child's quality of life, to use your words.
Yeah.
And maybe just there may be different options available now that might not have been when you started these treatments.
Oh, yes. Yes. And there's so many nuances I didn't go into, but there's some published data from the dermatology space where they don't even use steroids. They just use higher dose of the jack, and they don't even require it because it just works so well for the skin, especially. So I think in the future you might even see other studies, research studies, where they'll start with kind of almost like an induction where high dose jack for like 3 months. Don't even use steroids because steroids is like we call poison or something. I mean, it works well, it's a lifesaver, but with all the side effects. And then you go down to the lower dose. And they've done this in really skin predominant dermatomyositis where it works really well. So I think this is why I think this drug is exciting. But anyway, yeah.
Yeah, no, that's really exciting. And again, we all are kind of at different places on our journeys. So it's just great to know the options. And I think you brought up an earlier point, which is that things are moving quickly. And
Mm-hmm.
so it's always a good idea, in this case with Dr. Pike, to just bring forward your concerns. And maybe there's some new information that has come about in the last year.
Yes.
So one other question that came in by email a few different times was, we hear a lot about JAKs as a group. So
Mm-hmm.
does that mean that if one JAK works, are they interchangeable for every patient? Are they interchangeable for some patients?
Mm.
Do we know yet? Do we not have enough data?
Yeah, I don't think we have enough data. But I think because, tofacitinib was the first approved, I think now it's generic, so it's just easier to get. If your child has juvenile arthritis, a little bit of joint pain, then most of the doctors, could potentially order it for you and just get it approved off label. Um, so I feel like I don't think we know which one is better as of yet. Yeah. Um, but I don't think it hurts to if one didn't work. So right now in the adult population, we have these clinical conferences where, we try one, and then if it doesn't work, we actually increase the dose, like I was telling you, and then see if it works better, and then lower the dose to the kind of minimum efficacious dose that's already FDA approved. Yeah,
Okay,
but
great.
I don't think we know across which one works better. Yeah.
Yeah, and sometimes it's out of the hands of the parents and doctors, and it may be in the hands of the insurance.
Yes, that's true.
Um,
That's a good point. Yeah.
so one more question, and then we'll probably open it up to the group to see any live questions. But one more question that came in via email
Mhm.
was, it seems to parents, again, we're not in it every day like you are, but it does seem like this has there's been a bit of a momentum around the JAKs. So do we think that there's anything coming that we should be aware of in the JAKs, or where do you kind of view the JAKs kind of fitting into their role in the arsenal of treatments that our doctors are using?
Yes. So right now, I can give you hard data that um, there is a phase 3 that just finished enrollment that I helped design the trial. We're part of the trial. It's the brepocitinib, which is another JAK inhibitor. And they recruited almost 200 patients with adult dermatomyositis nationally and internationally. So it's the largest dermatomyositis trial. So that study is a registrational study. So I think it's really exciting because if it works, it could be FDA approved for unfortunately only adult because they didn't look at JDM, but they are thinking of looking into JDM as well in the future, I believe. And that drug, they added it to background therapy, and they just had to have at least mild muscle and mild skin involvement. So I think if this drug works, you could even use it earlier, right? Um, in the treatment of active dermatomyositis for adults at least. And hopefully that could translate to juvenile dermatomyositis as well. And then, as I told you before, there are trials in juvenile dermatomyositis with baricitinib. But those are phase 2 trials, and hopefully it'll get to phase 3. And those are looking at kind of naive recent onset dermatomyositis. Um, there is also another by a company called Galapagos, but they don't have a name for it. It's another TYK2 inhibitor. It's all in the JAK pathway. They are only looking at adult. It's a phase 2 trial, however. It's an oral drug as well. So you can see there's this whole space of JAK
Mm,
inhibitors. But I
yeah,
think the most exciting one is this Valor study, which we're going to
yeah.
have some top line results hopefully within the next year. And it's a registrational study, so that might be the next FDA. We're hopeful, but we don't know. We'll see.
Okay, so one more question that because you mentioned Valor. So, in your experience, I don't know if you're treating any adults with JDM. So the way it works for our patients is we're typically diagnosed as juveniles, but obviously everybody grows up.
Hmm.
So in your experience, are most of the treatments the same, whether or not you were diagnosed as a child or an adult? Would a trial in an adult be something useful that we might look at, or should we wait until we know more about juveniles?
I think it's very similar, extremely similar from what there are some nuanced difference, but I think if we look at the kind of at a molecular level of what's going on in the skin or the muscle, all the same kind of immune pathways are highly activated in both JDM and adult dermatomyositis. So I think it will be applicable, but since there's no phase 3 registrational study, um, you know, in JDM, I think it's just insurance is going to be a pain, but hopefully
Okay.
it'll lead that path. Yeah.
Well, we're used to that because we don't have any FDA approved treatments. So
There has to be one.
we all know how to contact our insurance as needed, sometimes weekly. So that's great. So you mentioned a tiny bit about signaling pathways. Do we want to, if you had to explain this to your children, how the JAK inhibitors work to calm down the overactive immune system that our children have, is
Yeah.
there any way that you would be able to explain it to a child? If we went to our children and said, your immune system is overacting. It's attacking your skin and muscle when we know that's not good. And we're going to switch to this treatment because it does what?
Yeah, that's a hard question. I was like, oh no, I have to answer. I was talking to. So I would say it would, dampen the inflammation in, your skin and muscle, or get rid of it, basically. So it
Great,
doesn't exist and continue to cause weakness in your muscles and inflammation in your skin, or rashes in your, yeah, in the skin.
great. Okay, and we will open it up to questions. I've said that, but one more that came in by the chat. So one
Yes.
thing that often our kiddos struggle with is the rash kind of coming and going.
Yeah.
So would a topical cream that's a JAK work just to put it on the rash when you have it? Or do
Mhm.
you feel like the rash is something that maybe indicates more treatment might be needed? Or could it be
Yeah.
both?
No, I absolutely think that that's very reasonable, and I have prescribed it. So you can get I was telling you what I think it's called Opalazura or Opalazura. I can't. Anyways, but there's a Jack
Oh,
cream.
Opsalura, Opsalura.
Opalura, yes, yes, yes. So that one is already FDA approved for eczema. So if your child has eczema, like fine, like you
Here,
can
I
ask
can,
your
and I
dermatologist to
can
prescribe it.
share the spellings. I will share the spellings afterwards with all of you because I don't want to.
Sure.
disrupt the questions just as we go to
Yeah.
questions. So
Um,
with that, I think Dr. Pike has done an incredible job of explaining such a complicated topic to all of us parents that are trying to navigate this journey while we've got fussy toddlers that don't feel well and teenagers that don't like prednisone, and it's all very complicated for us as parents. So we really, really appreciate your time to be here. So with that, I think we've learned a lot about JAKs. We'll just open it up to questions if there are any other questions that we didn't get to that you guys now have. So we'll take a minute to allow everyone to come off of mute.
If a patient were to start a JAK inhibitor, would they need to go off of some other meds typically, or did they, you had mentioned a little bit of like maybe an increased risk for clotting or something that would kind of, so I was just curious about that. We don't currently take one, but if we were to start, we are on a few other things. So
yes, yes. So it's really case by case. If the patient is already on like methotrexate and there's a lot of, inflammation that it's controlling already in the skin and the muscles, but we need additional agent, then I usually just add it on. But if it's really mild and it's just a little bit of rash in the hands or, the elbows and no muscle involvement, and my patient's like, I just don't want to take methotrexate. It's making my hair fall out, and I've been on it for 10 years or, then I'd be like, yeah, let's just stop it. And then let's try just that JAK by itself. Yeah. Oh, I wanted
Great.
just to say about the, I don't know if people know this, but because that medication that's approved for eczema, I can't pronounce it, but it's the, it's the,
Opsilura.
yeah, Opsilura, the ruxolitinib cream. The other way you can get it, if you have friends who work in compounding pharmacies, is that tofacitinib can be compounded at a compounding pharmacy, and your doctor can send an order to the compounding pharmacy. And so some of my patients have done that, and it's cheaper than try to go through insurance if you just want to pay cash. Anyways, that's just something. Yeah.
That is very helpful to know. So I think we've answered a lot of really tough questions here today. But again, the rash for some of our kids tends to hang around a little bit longer. So would you compare the Jack cream to other creams that children are using for rash? Do you have any experience comparing them, or what are your thoughts?
So I have used, I think I see this,
Yeah,
the tacrolimus kind of
Primacrymalis.
cream. Yeah. I have used that with success, especially my patients who have like eyelid involvement. It was so, I couldn't, she was on mycophenolate and the eyelid still red and, so that worked. But we haven't compared like which one's better per se. I think it would just have to be tried. So we don't know if it's better or not. But sometimes what I've heard for the tacrolimus cream is that it burns. And I remember my son has eczema, so I have tacrolimus cream, and he thought it burned too, but this was when he was younger. So I didn't end up using it for his eczema, but usually the Jack creams don't burn. That's what I've been told. So I don't know. Yeah.
That's very helpful.
Mhm.
So with that, Dr. Pike, anything that you wanted the parents to kind of be considering or thinking about that we haven't touched on?
I think we discussed, and you highlighted this so beautifully, Shannon. It's just that really we have that honest conversation with your physician about how your child is doing and how it's impacting their quality of life. Because I think as a rheumatologist, we're seeing all these patients and we don't, sometimes it doesn't come to the surface that, or we're not really realizing how much the adverse effects or a certain medication is affecting my patient. It's more like, okay, how are your labs doing? How does your skin look? How's your muscle? But it's also about how they're feeling and doing and how it's affecting their quality of life, So I think that's really important. I think it's a really exciting time for medications in myositis. There's so many clinical trials, at least in the adult space. Like we have I think 8 to 10 trials that are ongoing at the same time. And so hopefully that will also translate into, the JDM world as well. So I'm very hopeful about the treatments in myositis. Yeah.
Well, that's what we want to hear because our kids are, pretty near and dear to all of our hearts, as you understand as a parent. So with that, I think we will, first I want to recognize our, yeah, they're validating your comments.
Yeah.
I want to recognize our board members that are here. All of you that are part of CureJM means so much to all of us, but our board of directors really does a phenomenal job at funding our research, funding doctors like at Johns Hopkins and other members of our clinical care network, and making sure that our kids have as many treatment options as possible so that each of them can thrive. And I really want to recognize Denise Cook, Julie Haupt, Christine Alderfer. Thank you all so much for your extraordinary leadership and really all that you do as board members for our families. We're really, really grateful to you. And then to everyone, all of you for your participation. So for your financial contributions, your fundraising, your participation in town halls and in all of our support groups. We're really grateful to each of you. So with that, I know there's a couple other questions that have popped into the chat while we were kind of doing a wrap up. So we wanted to break at 45 minutes after so that parents could still have a chance to stay on and enjoy our parent or grandparent social time. It's a really great way to be able to connect with others that get you because you may know this, Dr. Pike, but for most of us, we're the only ones in our town that know what
Wow.
this is like to be a parent, right?
Wow. Yeah.
So many of us have not met other parents that kind of get what it's like on this journey with little ones or teens or adults. So it's really great to have that social time. So we'll take another 2 or 3 questions, I guess, since we have time and they keep popping in. So Jeff was wondering what would be the advantage of a topical treatment? So that was kind of what I was getting at with my question as well, is there's a lot of confusion in our parent groups about what the skin means and what the rash means. So some people find success with just treating the rash topically, but for some kiddos, it seems like that is an indication that something is simmering underneath, that there's inflammation in the body that might be later showing up in the muscles or in other ways. So would you want to speak at all from your experience of,
Yeah.
for some kids, maybe would a topical work, but for other kids, the rash might mean there's more that needs to be investigated.
Yeah. So I think it's really important to understand what type of dermatomyositis, at least in the adult population, my patient has. So if they're like amyopathic, meaning they don't have any muscle involvement and they're stable like this without any muscle involvement with just skin disease, then I have patients who just have long-standing, just, rash on the hands. And they don't want to, like, if I were that person, I also would not want to be taking an oral medication because it's only on my hands and it's not severe. So it's extremely rare to see that at Hopkins because we see all the kind of more more resistant cases. But I have seen that. And then they're like, well, why do I need to take X medication or methotrexate when it's just on my hands and it hasn't progressed at all? So if they're in that, what we call amyopathic group, which means no muscle involvement, then I think it's totally fine to do that. Of course, if there's new symptoms like I'm fatigued and I have weakness, then your doctor should check, your muscle enzymes and make sure there's no brewing muscle involvement.
Yeah.
I guess it's hard. So I didn't think about this, but in children, they might not tell you I'm weak or, these things, right? So that's really hard. So I guess I would leave that to our JDM experts because in our case, they're telling us I'm tired, I'm weak. And, this feels just like when I had really active skin and muscle involvement.
Yeah.
So, yeah.
That's great. So one other question, just because you did sort of bring it up. I do think that what is confusing to parents is that some children do just have skin, and some children, the skin is indication of brewing inflammation. And we sometimes say it's just the skin, it's not the muscles yet.
Right, right.
So when there's, it can be just the skin for some kids, or it can be just the skin and not the muscles yet for other kids. And so that's why it's really important to have these conversations with your doctor who knows your child's case. You sometimes a parent might, share with another parent, the cream worked for me, but that may not work for you.
Right.
And then one other question, we've got about 3 minutes left here for questions, is do you have any indication from your data about how patients with calcinosis might think about integrating JAKs into their care? Not probably stopping all their other treatments, but is there anything that could be considered hopeful or promising? Because we find calcinosis in kiddos pretty difficult to treat sometimes.
Yeah, that's like the hardest complication, I think, in dermatomyositis. I do think it matters when my patient is exposed to the JAK. So in our proof of concept trial, we definitely saw patients' calcinosis size decrease. We had objective evidence on imaging, on MRI and X-rays that the size decreased as well. And there's also data in juvenile dermatomyositis that it may help. But the big question is, oh, is it because I'm just getting rid of all the inflammation and it's not laying down extra new calcium areas? And that's the reason why the calcinosis improves. Not that it's directly affecting the calcium deposits to disintegrate. So we really don't know. But I think it was really astonishing and striking to us. And so I think more data is needed. But if there are, my experience has been in the adult population that if there are calcium deposits that are extremely hard and old, those are kind of set there. It's probably not going to dissolve. But like the smaller, softer ones, I've seen them dissolve. And this is very anecdotal, very small numbers. And hopefully in the future, we'll have bigger studies to address that.
Yeah, that's a tough one. Okay, so last question, we've got about a minute. So I think you've done a really good job of explaining to us when we might want to have conversations with our doctors about whether or not, a JAK might be something we might integrate into our care plan. Would you, as a parent, have those conversations with your doctor at the beginning of your journey, at the middle of your journey, at the end, or do you kind of feel like that's always an ongoing conversation?
I think it should be at the beginning. I think you should know all the treatment options. And then after their assessment, they can tell you these are the medications that I recommend as your physician. And then when things evolved, let's say they're like, no, she really needs the IVIG because she has problems swallowing and all these things. But after a year, she's, significantly better, doing sports and all these things. Then maybe that's when you say, okay, let's try to taper this off so she could, go on trips without being hooked to the pool every 4 weeks or something like this. And try a different agent. But I think it's good to know upfront. Like that's how I do it for my patients as well. Like we talk about everything and then we have the list of the medications that are available and even clinical trials from the beginning so that they're aware that we have all these options to consider at any point in time.
Yeah, I think that's a really good point. And I love the way that you say just to keep those conversations ongoing and to have those conversations with your doctor, no matter where you're at in the journey. So I think that wraps us up. I know there's more questions in the chat. We will reply by email with all of the rest of those. A couple of housekeeping items. This will be posted on our resources section of our website, and I will get that emailed out to everyone in the next, by the end of the day today. So with that, I want to thank again all of our families for joining us and our board of directors for being here as well. As well as I see we had a special guest appearance from our executive director, Jim Minnow, and also Dr. Andrew Heaton, our chief executive officer, our chief scientific officer, who is the one that coordinates all of the wonderful research that has made this update here today possible. Andrew has been out in front of making sure we're on the cutting edge of of the jacks and everything else for our kids. So we are very grateful to you, Andrew. And with that, we will thank Dr. Paik. There are so many kudos and thanks coming in the
Oh,
chat,
thank
Dr.
you.
Paik. I think you really did an excellent job of helping us understand how this might fit into our various treatment plans that all of our children have. So we're very grateful to you. It was a wonderful, wonderful talk. I appreciate all your expertise, and hopefully all of our children can someday grow up and live very near Johns Hopkins. And we can call you one of our amazing care providers for
Yes, absolutely. We'll be honored. Thank you for having me.
Thank you so much for coming. So